Okay, let's unpack this. We're embarking on a deep dive today into, well, one of the most critical and frankly chaotic realms in healthcare, mass casualty incidents or MASCALs. These are events where just a huge number of people are injured or suddenly fall ill, all at the same time, pushing medical systems to their absolute limits. And to really get our heads around the mindset required, we're going to kick off with this really powerful, almost stark quote from Dr. Baron Larry, Napoleon's surgeon, way back in 1812. He said, "Those who are dangerously wounded should receive the first attention, without regard to rank or distinction. They who are injured in a less degree may wait until their brethren in arms who are badly mutilated have been operated on and dressed, otherwise the latter would not survive many hours, rarely until the succeeding day."
Wow. I mean, that quote isn't just history, is it? It feels like the very foundation of MASCAL thinking. It tells you immediately that we're talking about a fundamental shift in, well, in medical philosophy.
Absolutely. And what's truly fascinating here is just the sheer breadth of what we mean by MASCAL. When we use that term, it's not just one type of disaster we're picturing. We're talking about, well, everything from intentional terror-driven events like mass shootings and bombings.
Yeah.
Think back to the tragic 2013 Boston Marathon bombing and the immense immediate challenge it posed. But it also includes non-intentional things like major industrial accidents, big building fires, or even vast natural disasters, hurricanes, earthquakes, tsunamis, things that overwhelm everything. And while maybe historically these were less frequent in daily civilian life, the past decade has unfortunately brought increased global instability. And that's led to a significant and frankly absolutely necessary focus on preparing for them. This rising frequency, especially of things like terrorist acts and large-scale accidents, has squarely brought MASCAL preparedness right to the forefront of medical training worldwide.
Right. So our mission today, really, is to give you a shortcut to being truly well-informed on the surgeon's, well, indispensable role in these incredibly high-stakes scenarios. We're going to try and extract the most important nuggets of knowledge, explore some maybe surprising facts, and help you grasp this complex field like an elite professional would. And we're going far beyond just the clinical care, the operating room stuff. We're looking at the crucial, often underappreciated non-clinical aspects that can literally make or break a MASCAL response. It's about understanding the entire ecosystem of care, wouldn't you say, and not just one piece of it.
Precisely. The whole system has to work together.
So when we talk about these MASCAL events, the core challenge, almost without exception, revolves around major traumatic injuries. We're not talking minor scrapes or sprains here. These are severe injuries demanding rapid triage, comprehensive evaluation, and, crucially, immediate surgical or other procedural interventions. And this immediately highlights the surgeon's central role, doesn't it? Whether they're operating right there in the emergency room during the initial chaos or later in a surgical theater, their expertise, their ability to make swift, life-saving decisions, it's just absolutely paramount.
And if we connect this to the bigger picture, one of the most critical and I'd say often profoundly misunderstood concepts in MASCAL care is triage, which at its heart just means the sifting and sorting of patients. It sounds simple, but it's incredibly complex in practice. This is the physician-driven aspect that truly sets the stage for success or failure. It determines who gets care first and, crucially, how those incredibly scarce resources are allocated. And it's a fundamental, often counterintuitive shift from what we do every day, which is providing optimal care for every individual. In a MASCAL, you shift to optimizing outcomes for the largest possible group. It's a tough mental and ethical pivot for healthcare providers. Really tough.
I can imagine.
And here's something surprising, a bit of a paradox, really, that often catches people off guard when they think about MASCALs. In most real-world events, the majority of patients, often around 50%, actually have minimal injuries. And counterintuitively, these less severely injured folks tend to arrive before the 20% or so with severe or life-threatening injuries.
That's fascinating, and it almost goes against our natural instinct, doesn't it? You'd think the most critical would somehow get there first.
You would.
So what's the practical implication of that? For the initial triage officer, are they almost fighting an instinct to help the people right in front of them, the ones walking and talking, while knowing the worst is yet to come?
That's a fantastic point. It's not just counterintuitive, it's a critical potential pitfall in those first few minutes. The practical implication is that the initial triage approach needs to be incredibly specific and disciplined. You have to avoid overwhelming critical resources like your trauma bays or your operating rooms with those who don't immediately need them. The walking wounded, as they're often called, they frequently self-transport. They arrive in private cars, maybe even on foot. Much faster than those who are severely hurt and need careful extraction and ambulance transport.
Right.
So the triage team has to quickly identify and direct those people with minor injuries to separate areas while staying acutely aware that the truly critical cases are coming, and they will demand immediate, high-level resources the second they hit the door. It's like preparing during the calm before the storm, but knowing that storm is definitely on its way.
Which brings us to the history of this, because here's where it gets really interesting, delving into the very origins of this vital concept. As you mentioned earlier, the term triage itself was actually coined by Napoleon's surgeon, Dr. Baron Larry, whose quote we started with. His principles were, well, revolutionary for the time, weren't they? Born out of sheer necessity on those brutal Napoleonic battlefields.
Absolutely. Battlefield medicine drove so much innovation.
Triage concepts came directly from those battlefield demands. The focus was on salvaging the greatest number of casualties in environments where resources, surgeons, instruments, time, even bandages were incredibly scarce. Larry's principles that focus on the most gravely wounded first, regardless of rank, were stark but incredibly effective for that context. Prioritize care based on injury severity and the likelihood of survival. It wasn't about who was the general, it was about who could actually be saved to fight another day or simply to live. A radical idea then.
A truly radical idea. And the evolution since then has been profound.
Yeah, every major conflict since Napoleon's time has pushed triage and MASCAL management forward. The consistent trend has been bringing life-saving care closer and closer to the point of injury using more sophisticated tiered systems. Think about modern battlefield medicine compared to Larry's time. Night and day.
Completely different.
And this vast military experience full of hard-won lessons, often paid for in blood, has enormous potential for direct application to civilian MASCALs. We'll definitely circle back to that synergy later, how military and civilian systems can learn from each other.
That's a crucial historical context. And it raises an important question. What exactly are we talking about when we use these specific terms like triage, MCI, or MASCAL? It's really vital to have clear definitions, especially in these high-stakes, fast-moving situations where every second counts and miscommunication can be disastrous.
Right. Clarity is key.
Okay, so first, triage in its general sense. It's that process of sorting patients to achieve the core MASCAL goal, the greatest amount of good for the highest number of patients. It's essential for any trauma system, really, but absolutely pivotal for optimizing survival in what we call multiple casualty incidents, or MCIs. Now, you can have triage without a MASCAL. A single bad car crash might require sorting injuries, but MASCAL always requires triage. You just can't manage it otherwise.
Makes sense.
Then we have field triage. This is done at or very near the scene, usually by EMS providers. Its main purpose is to quickly assess patients and decide which hospital is best equipped for their injuries. The goal: efficiently concentrate the seriously injured at major trauma centers without overwhelming those centers with minor cases. It's about smart distribution across the region.
Okay, so sorting before they even get to the hospital.
Exactly. Then, once they arrive, you have hospital triage. This is the resorting process inside the medical facility. Patients get put into predefined categories based on local systems, things like non-survivable, minimal or delayed treatment needed, or highest priority, meaning they won't survive without immediate intervention. This internal sorting is crucial for efficiently using hospital resources like ORs and ICU beds.
Okay, and you mentioned two other key terms related to accuracy: under triage and over triage.
Yes, critical concepts. Under triage is when seriously injured patients get sent to facilities that just don't have the necessary expertise or capability. Like sending a severe head injury to a small community hospital without neurosurgery. In routine, day-to-day trauma care, the absolute focus is to avoid under triage at all costs. You want the worst injuries going to the highest level of care, always. Missing that can be fatal.
Right, that seems obvious. But over triage.
Over triage is the flip side. It's when patients with minor or non-urgent injuries are sent to major trauma centers or are put into critical care beds they don't really need. Now, you might think, better safe than sorry, right? But in a true MASCAL, over triage is incredibly dangerous. It bogs down the whole system. It creates bottlenecks in critical areas, the trauma bays, the ORs, radiology, and it can actually lead to increased adverse outcomes for the truly critical patients whose care gets delayed because resources are tied up. This is a really critical distinction in MASCALs compared to day-to-day trauma. When resources are overwhelmed, over triage actively hinders life-saving care.
So To really hammer that home, it's not just about getting the sickest people to the right place. It's equally about not sending the less sick people to the place where they don't need to be, because that drains resources. Is that the core idea?
Absolutely. That's the core idea. Our sources really highlight this vividly. Imagine a graph plotting, say, the percentage of patients inappropriately sent to high-level centers, the over-triage rate against the death rate for the critically injured patients during actual terrorist bombings. What you see is a striking, almost linear increase in critical mortality as the over-triage rate goes up. It's not just theory, it has direct fatal consequences. The correlation is incredibly strong. So sending too many low-acuity patients to your main trauma center during a MASCAL can be just as detrimental, maybe even more so, than missing a critical injury sometimes, because it paralyzes the system's ability to save the most lives overall. Just for precision, technically, over-triage is calculated as 1 minus specificity, incorrectly identifying those not seriously injured as severe. And under-triage is 1 minus sensitivity, incorrectly identifying those who are seriously injured. In a MASCAL, you need to optimize both, but the focus has to shift heavily towards controlling that over-triage rate to preserve those critical resources. You have to protect your capacity for the truly dying.
That's a really eye-opening distinction. It definitely changes how you think about emergency response priorities, and it leads us perfectly to another absolutely crucial point. The fundamental difference between a multiple casualty incident, an MCI, and a true mass casualty MASCAL incident. Understanding this difference drives the whole response strategy.
It really does. The labels matter.
Let's start with a standard trauma incident. This is what a level 1 trauma center handles daily. One, maybe a few patients. They have excess resources, expertise, time. It's routine for them.
Business as usual, relatively speaking.
Then, a multiple casualty incident, MCI. This involves multiple injured patients, maybe dozens, but, and this is the key, adequate resources are still available. The system isn't significantly stressed. A big level 1 trauma center might handle, say, 20 severely injured patients from one big highway pileup as an MCI. They can absorb that without fundamentally changing how they operate or running out of critical supplies. They have the surge capacity.
They can stretch, but they don't break.
Exactly. But mass casualty, MASCAL incident, that's an entirely different beast. This is when the number of injured patients or, critically, the resources needed to care for them exceeds what is available. This fundamentally stresses the entire system, the hospital, the region, the individual providers. This is the moment where usual protocols get abandoned. The focus dramatically shifts from optimal individual patient outcomes to achieving the greatest good for the greatest number. Group outcomes become the priority.
And that's that profound, difficult ethical shift we talked about. Staff had to be mentally prepared for that.
Absolutely. And to really visualize this, imagine that graph, the sigmoid curve our sources mention. It shows how the level of care just plummets once a facility's surge capacity is exceeded. As the critical casualty load keeps rising, the system goes from handling an MCI okay to suddenly spiraling into a MASCAL, where the quality of care for any individual patient drops dramatically. Like a dam breaking, once you're past that tipping point, control is lost.
That curve graphically shows the breaking point.
And then even beyond that, you have a disaster incident. This is usually a huge natural event, hurricane, earthquake, or a massive man-made MASCAL. Overwhelming patient numbers, A&D, crucially widespread destruction of local infrastructure, including maybe the healthcare facilities themselves being damaged or cut off. Roads out, power gone, that just compounds the challenge immensely.
Right, and the key differentiator in all of this truly isn't just the raw number of patients. It's the resource availability and the facility's surge capacity. You know, many events that get initially labeled MASCALs in the heat of the moment are actually MCIs when you look closely. A true MASCAL rapidly overwhelms capacity, especially if it's coupled with infrastructure damage. And this fundamental distinction is precisely why surgeon involvement at every level, planning, education, training, is so ideal for system success. Their deep understanding of injury physiology, the real-world demands of critical care, resource limitations, it's irreplaceable. They see the whole picture.
It's clear that getting these definitions straight is foundational. So now that we have that groundwork, let's talk principles. Even though MASCALs are wildly different, decades of experience and countless after-action reviews have revealed these common threads, right? A kind of top 10 list of principles for effective MASCAL management. Let's dive into what these mean practically.
Yes, these are the pillars of a good response.
Okay, first, triage is dynamic. It's not a one-shot deal, not just slapping a colored tag on someone and moving on. It's an ongoing process at the point of injury, during transport, at the hospital door, even inside the hospital. Patients get re-triaged as their condition changes, for better or worse, or as resources shift. Why is that so hard for us to grasp sometimes? Is it just the chaos? It's partly the chaos, and partly because it feels like a rapid sort at the start. But trauma patients especially can change incredibly quickly. Someone you initially tag as delayed might suddenly start bleeding heavily and become immediate. Or a minimal patient could develop breathing problems. Being dynamic means constant reassessment, constant flexibility, which is incredibly hard under extreme stress. It demands a proactive mindset from the triage team, always looking ahead, always reevaluating.
Okay. Second, the MASCAL goal itself is fundamentally different. Do the best for the most, not everything for everyone. This is that profound ethical and practical shift. It means accepting, sadly, that some patients might not get the full care they'd receive normally because those resources are desperately needed to save more lives overall. It's that utilitarian calculus, and it goes against a provider's core instinct.
It's one of the hardest parts of MASCAL response. Third, and we've hit this hard already, triage equals success or failure. Accurate, effective triage is the make-or-break factor. Good field triage is especially vital for regional systems, making sure patients get routed correctly from the start to avoid those deadly bottlenecks.
Absolutely critical. Fourth, know your system. Triage doesn't start with the patients. It starts before they arrive, with understanding your available capabilities, resources, personnel. Our source material talks about this zero survey concept. It's the crucial first step for any experienced triage officer or incident commander. You rapidly assess the current status of everything critical before the first casualty arrives. We're talking ER beds, yes, but also OR capacity, ICU beds, blood bank levels, pharmacy readiness, radiology, lab turnaround times. You need a snapshot of your entire hospital's readiness, and you have to notify key ancillary services to stop non-urgent work, free up staff, and 2 critical non-clinical areas. Patient administration PAD for tracking and ID and security. Activate them early, neglect them, and you get chaos later, misidentification, medication error.
That's huge, that proactive assessment. Okay, Fifth, single entry, one-way flow inside the hospital. Patients should enter through one controlled point and move in a clear path. Prevents congestion, reduces confusion, keeps things orderly for rapid movement to treatment areas.
Keeps the traffic moving.
Sixth, redundancy of capability, not duplication of action. This is about avoiding inefficiency when you're already stretched thin. Have backups, alternative pathways, multiple trained people for key roles, but don't have 2 teams doing the exact same primary assessment on the same patient. That wastes time and resources. You need backup options, not just repeating the same effort.
Efficiency is paramount.
Seventh, pre-prepared documentation. Have MASCAL chart packs paper is often more reliable than electronic systems that might crash and admission packets ready at the triage intake. Prevents KDOS, reduces errors like misidentification or med errors, streamlines things when time is everything. Trying to print forms for hundreds of patients in a crisis, forget it.
You need those packets ready to grab and go.
Eighth, use validated triage systems. Things like DIME, START, SALT. Pick one that fits your system and train everyone on it relentlessly. Familiarity breeds efficiency and reduces thinking time under pressure.
Practice makes proficient. Ninth, the senior triage officer. This person must be one of the most experienced, organized people you have, ideally with a deputy for communication and recording. This isn't a job for a junior resident. It's a critical leadership role needing clear thinking, decisiveness, and calm under fire.
Absolutely. And finally, 10th, scene security and safety are paramount. Don't rush into an unsecured scene. Medical teams need confirmation it's safe before going in. Becoming a victim yourself just adds to the chaos and diverts resources. Close collaboration with law enforcement from moment one is key here.
Provider safety first. Okay, building on those principles, the last decade or so with combat operations and major civilian events has given us invaluable, often painfully learned lessons. The key is to rigorously learn from every event through detailed after-action reviews, or AARs.
Right, the learning loop.
Exactly. The AAR process is non-negotiable for getting better. These reviews need to be incredibly thorough, done as soon as possible afterward while memories are fresh, and held at every level, individual units, the whole hospital, the entire regional system. The purpose: identify strengths, weaknesses, and critically, opportunities for improvement. And crucially, AARs have to lead to formal action plans, compile the findings, prioritize changes, and continuously adjust the MASCAL plan based on this feedback. It's about institutionalizing improvement.
So it's not just a meeting, it's a process that leads to change.
It has to be. And from these AARs, a pretty consistent set of top 10 common MASCAL lessons learned have emerged. They give us a roadmap for preparation, often highlighting what went wrong before and how to prevent it next time.
Okay, let's run through those. First, no one is safe. MASCAL events can happen anywhere, anytime. They seem to be increasing. Preparation isn't just prudent. It's an absolute necessity for every community, every hospital.
You can't assume it won't happen here. Second, know your assets and capabilities. Deeply understand what's available at every level, pre-hospital, transport, individual hospitals, their specific specialties, and the overall regional system. Know the whole network, not just your own facility.
Third, leadership and a clear chain of command. Absolutely crucial, especially for allocating resources, trauma teams, evacuation assets during the chaos. Goes back to point 2, you can't lead or allocate effectively if you don't know what you have.
Clear command prevents paralysis.
Fourth, appropriate scene triage and point of injury care can genuinely turn a potential MASCAL into a more manageable MCI. The textbook example here is the 2013 Boston Marathon bombing response. The excellent scene care and immediate effective triage by first responders and medical personnel distributed the seriously injured patients evenly across multiple capable hospitals. No single center got totally overwhelmed. That was a remarkable achievement, directly saved lives because it preserved surge capacity across the system.
A prime example of good field triage. Fifth, the senior triage officer's importance just cannot be overstated. Historically, maybe this role was underestimated, sometimes given to less experienced people. Big mistake. It's now recognized as paramount. This person needs advanced trauma knowledge, exceptional leadership, killer communication skills under pressure. Often, it's best filled by an experienced trauma surgeon or EM doc, someone who's seen the worst and can make rapid, accurate calls.
Sixth, scene control and safety. Vital. An organized security plan is integral. Prevent secondary injuries, protect staff, limit entry points to the scene and the hospital. Hospitals themselves can become chaotic zones, media, anxious families, onlookers. Crowd control, allowing only mission-critical staff in, is a key security function to let medical teams do their work.
Protect the perimeter, protect the providers. Seventh, excellent patient flow and throughput are required for a good plan to work. Prevent bottlenecks, especially in the ED and radiology. That one-way flow concept helps keep things moving, like a well-oiled machine, not a clogged drain.
Eighth, in a true MASCAL, overwhelming the ED, establish a separate area for the minimally injured. Get the walking wounded out of the main critical care area. Use outpatient clinics, a gym, a tent outside. Staff it with providers who can examine, retriage if needed, and discharge or hold those who don't need immediate high-level care. Protects critical resources.
Keeps the ED clear for the sickest. Ninth, this raises the question, what's the immediate medical focus once patients are sorted? It boils down to hemorrhage control, airway, and breathing. Hemorrhage control, stopping the bleed, has to happen along the entire continuum from the first responder to the OR. It's often the most immediate preventable life threat.
Stop the bleed first.
A, B, C, but heavy on the C for catastrophic hemorrhage first.
Precisely. And 10th, blood products are often scarce initially. Have a clear plan to manage your blood supply and prevent running out. If you expect long transport times, seriously consider pushing blood products forward to triage sites or intermediate facilities to start resuscitation earlier. Forward deployment of blood can be a game changer. Wow, okay. So it's clear that while, yes, surgeons operate, their role goes way beyond that. They must be involved in all the non-clinical stuff, planning, preparation, training. Our sources really hammer this. Often these planning tasks get assigned to non-surgeons, maybe even non-clinicians. And that, as we've seen, leads to unrealistic plans that fall apart in a real event. Surgeons bring that indispensable understanding of injury, patient flow, resource limits.
Their input is vital for realistic planning. And to help us remember all these core principles and the surgeon's broad role, we can use that mnemonic, TRIAGE. It's a great memory aid, a guide for prep and execution that, elite professionals rely on.
Okay, let's break down TRIAGE, starting with T.
T is for training, specifically in-hospital responsive local training. Mark Twain nailed it. Training is everything. Effective leadership and comprehensive realistic training are absolutely fundamental. While surgeons might not always be doing the point of injury care themselves, their involvement in planning and training for the whole system is critical. Given their overview of trauma care and physiology, they're uniquely positioned for oversight and leadership and training. They spot bottlenecks others might miss.
So they help design the training, make sure it's realistic.
Exactly. And part of that training involves predetermining who the triage officer will be, not deciding in the heat of the moment. This person needs to be highly experienced often, that trauma surgeon or senior ED physician, someone who can rapidly spot life threats, make tough calls. And you need redundancy. Backup triage officers trained and ready in case the primary is unavailable prevents a single point of failure.
Good point.
That triage officer also needs great situational awareness. Understanding the tactical situation, estimated casualties, secondary event risks, how effective field triage is crucial for managing resources and upholding that MASCAL goal. Best care for the most. It's a bird's eye view. And you need predetermined triage locations. Plan for at least 2 flexible options. A primary spot near the ED for smaller events, and an external primary site for larger ones that exceed internal capacity. Then secondary triage happens inside. But always, all patients enter through one controlled point, with security locking down others.
Makes sense. Keep it controlled.
And the triage team itself is key. The officer needs support. A patient admin, PAD person for tagging tracking, a nurse coordinator acting as bed manager, and crucially a nurse or medic right there with basic bleeding control supplies. Doing immediate hemorrhage control at triage, slapping on a tourniquet, packing a wound can actually downgrade a patient from immediate to delayed. That massively improves flow and outcomes by freeing up critical resources right away.
So stopping the bleed right at the door can change everything.
It really can, which leads to the need for comprehensive training across the whole hospital. Not just the ED. REs, ICUs, they all need to be part of realistic MASCAL drills.
Right. Perfunctory training just gives a false sense of security. You need realistic, resource-intensive drills with surgeons involved at all levels to find the weak spots throughout the patient's journey in the hospital. Where does the system break down after the ED?
Exactly. Rehearse the whole pathway. Okay, next in triage is R for readiness, regional field triage readiness. Ben Franklin said, by failing to prepare, you were preparing to fail. Couldn't be truer here. Regional and hospital readiness is a big investment, yes, but it pays off massively and saves lives when disaster strikes.
An investment you hope you never need, but have to make.
Precisely. Regional coordination is essential. Seamless teamwork with EMS, first responders, multiple trauma centers, especially where you have several level 1s, or maybe none. Surgeon involvement in regional trauma advisory councils, RACs, is key for a systematic approach. You know, the military's single command for medevacs offers a model. Civilian side is trickier. Private ambulances, different hospital leaders, but aiming for unified regional command in MASCALs is the goal.
A single conductor for the orchestra, basically.
That's a good way to put it. And field triage guidelines are usually based on national standards, like from the ACS-COT, those 4 steps: physiologic, anatomic, mechanism, special considerations. Patients hitting criteria go to the highest level of care available. But these protocols must be locally tailored, tested for sensitivity, specificity, how well they identify the sick and the not-so-sick, trained thoroughly, and monitored by experienced docs and surgeons who can tweak them based on real-world performance.
And this brings us back to that tricky balance between over-triage and under-triage in the field, doesn't it? You said in Escalez, the focus shifts. Can you elaborate on that again? It feels critical for that elite professional understanding.
Yes, absolutely critical. It's where the MASCAL mindset really diverges from routine trauma. Normally, we tolerate a fair bit of over-triage, sending less injured patients to trauma centers because the absolute priority is not missing a critical injury, avoiding under-triage. High sensitivity trumps high specificity. But in a MASCAL, that calculation flips. If you have, say, 20 truly critical patients needing immediate OA-ICU care, and 50 minor ones arrive at the same time, if your field triage sends even half of those 50 minor injuries over triage to the same level 1 center as the 20 critical ones, you paralyze that center. The minor injuries tie up beds, staff, scanners, ORs that are desperately needed for the dying. It directly causes delays, increases complications, and raises mortality for the ones who truly needed those resources right now. So in a MASCAL, there must be an equal, maybe even greater focus on avoiding over-triage, improving specificity, alongside minimizing under-triage, maintaining sensitivity. It's an incredibly tough balance, but essential to preserve those scarce life-saving resources. You have to protect your core capacity.
That's a really clear explanation of a very difficult trade-off.
It is. Then there's casualty identification and tracking, a huge challenge in the chaos. Standardized triage tags help display info, but they get lost, become unreadable. Their use has to be part of a larger tracking system and needs to be rehearsed. And readiness training must consider capability versus capacity. Capability is what services you offer: neurosurgery, vascular, IR. Capacity is how much you have beds, blood, OR slots. You need both. Newer web-based tools help track this regionally in real time, which is vital for smart field triage.
Knowing what you have and how much of it, constantly updated.
Exactly. Next, IM for integration of systems, essential to save lives. Integrating multiple hospitals, incident command, pre-hospital, EMS, in-hospital departments. Seamless coordination is the goal. Think about events like the Las Vegas shooting. Level 2 centers often got hit hard initially. Their integration and communication with Level 1s was critical for transferring patients who needed higher care.
So Level 2s are vital partners.
Absolutely critical partners. And in-hospital integration too. Blood bank, transport, radiology, PAD, ORs, they all need to be coordinated to avoid internal bottlenecks. This needs serious training investment, realistic drills that stress the system to find the weak links. And backup communication between departments is key.
Okay, TRI, next is A.
A for adaptable. Teddy Roosevelt, do what you can with what you have, where you are. That's the MASCAL's spirit. Plans are essential, but they can't predict everything. Leadership, triage, training are crucial. But the ability to adapt to the unforeseen is paramount. You have to be able to improvise intelligently.
Plans are a starting point, not a rigid script.
Exactly. Triage and management are dynamic processes. Resource levels change, the tactical situation evolves, decisions have to adapt. That senior triage officer needs incredible situational awareness, especially since patients arrive unpredictably, the sickest might be last. They have to constantly adjust the plan. And you need redundancy in communication. Fail-safes are essential, so all teams, local and regional, stay informed as the situation adapts. Communication failure unravels everything fast.
Makes sense. G.
G for grow, embracing the elements of a learning health system. This is about continuous improvement. Capturing, processing, acting on feedback, and lessons learned from every event, real or drill, is vital for the next one. Building institutional memory.
Don't make the same mistakes twice.
Precisely. Done primarily through after-action reviews, AARs. As soon as possible after an event, at every level, focus on what worked, what didn't, identify suboptimal outcomes, harm, near misses, but in a non-judgmental, non-punitive way. Encourage open feedback. Goal is learning, not blaming.
Creating a safe space to learn from errors.
Yes. And the AAR must lead to a formal action plan. Prioritize changes, integrate them into higher-level plans. This institutionalization of continual improvement is what defines a learning health system. The NASOM Zero Preventable Deaths report really called for this overhaul of national trauma systems based on that very principle. Learn, adapt, improve, continuously.
Okay, and finally E.
E for exsanguination control, along the entire continuum. Colonel Sen's quote, "The fate of the wounded lays with those who apply the first dressing. Stopping the bleed, it's primal."
Back to stopping the bleed.
Always back to stopping the bleed. Think of Dr. Larry doing rapid amputations on the battlefield. He knew controlling major hemorrhage was key to survival. Basic hemorrhage control and airway management aren't just hospital tasks. They must be part of triage for the most forward deployment point. Triage teams need tourniquets, hemostatic dressings, and the training to use them immediately.
Pushing life-saving interventions forward.
Yes, because study after study, military and civilian, shows most preventable trauma deaths before surgery are due to hemorrhage, especially in bombings or shootings. It's the biggest killer early on. This makes high-yield training in basic hemorrhage control a top priority. Things like the Beacon course from the ACS Stop the Bleed campaign. It's efficient, cost-effective, life-saving. Ideally, all MASCAL personnel should be certified and have immediate access to modern hemorrhage control tools. Make tourniquets as common as Band-Aids in first aid kits.
Universal basic hemorrhage control skills. Powerful. Okay, so we've covered principles, lessons, the triage mnemonic. Let's shift to some operational nuts and bolts. The practical stuff that makes a response actually happen.
Right, the mechanics of the response.
Understanding the Hospital Incident Command System, HICS, seems key here. It's the standard U.S. plan for sustained responses to big events, right? And all hazards approach, flexible incident commander, 4 sections, operations, finance, logistics, planning. Sounds structured.
It is structured and it's important, but this raises a really important question about its timing and limitations in MASCALs.
Yeah.
HICS often has a significant delay. Getting it fully activated and operational takes time. In most single-event MASCALs, there's a sudden bombing. The active shooter, HICS, will likely not be fully up and running during that critical initial phase of patient arrival and urgent care.
Okay, so it's not for the immediate first wave.
Not usually for the immediate chaos, no. Its real strength is in prolonged events. Think Hurricane Katrina aftermath. That's where HICS shines. managing sustained operations, ongoing resupply, coordinating multiple agencies over days or weeks, handling finance and logistics for the long haul. The initial response needs to be rapid, pre-rehearsed, almost automatic, independent of a full HICS activation.
Good distinction. Okay, security. Another crucial, maybe often overlooked element. We talked about scene safety, not rushing in.
Absolutely critical.
But security inside the hospital is also huge, right? Not just against threats, but managing the environment. Protection from media, maybe frantic families, onlookers, crowd control to stop them hindering care.
Exactly. Crowd control is a primary security function in a hospital MASCAL, keeping corridors clear, managing waiting areas, preventing interference. It's vital.
Security needs to control access points too, right? Only mission-critical staff allowed in, securing all entrances.
Yes, lock down the facility except for the designated patient entry point. And security, along with medical staff, needs plans to manage difficult situations, psychiatric casualties, combative patients. Surgeons really need to advocate for security's deep involvement in MASCAL training to cover these things.
Right. Communications, another bedrock. Multiple systems needed, regional and local, and they must be rehearsed.
Absolutely essential and complex. Multiple systems, fully rehearsed.
Yeah.
Regionally, routine EMS radio traffic can become instantly chaotic. Training has to include coordinating multiple private ambulance companies through a central dispatch to regional hospitals effectively.
And what if cell service goes down? Disabled deliberately or just overloaded? Backups like radios, satellite phones, even landlines are crucial, aren't they? Otherwise, EMS can't talk to hospitals, hospitals don't know what's coming. Paralysis.
Total paralysis without backup comms. Locally, inside the hospital, you need robust alert rosters to call staff in. Even if they hear on social media, official notification and clear reporting instructions are vital. And the hospital's public affairs office needs to be ready for the media onslaught. One authoritative voice, accurate messages, managing interviews to prevent chaos and misinformation. They can also use social media strategically, blood drives, road closures, etc.
Documentation and patient tracking sounds like a nightmare in that environment. Patients misidentified, records incomplete, people lost in transfers, electronic systems might fail.
It is a nightmare scenario if you're not prepared. Balancing expediency with standards is tough, but efficient, accurate tracking is imperative. You have to know who is who, what's been done, where they are.
So low-tech solutions often win. Paper charts, maybe writing directly on the patient, or dressings for critical info during transfers. Having pre-made MASCAL packets.
Often, yes. Simple, reliable, low-tech is key for that initial phase. Pre-prepared MASCAL packets with simplified paper charting, patient labels, triage tags, absolutely essential. Ready to grab and use instantly.
Okay, what about broader community elements, especially in big disasters affecting a whole region?
Yes, several things come into play. Social media, as we touched on, can be used for official messaging, blood drives, traffic updates, but accuracy is paramount to avoid panic or misinformation.
One long tweet could cause chaos.
Exactly. And this raises another important question, often missed in planning. What about language barriers? The Asiana Airlines crash in San Francisco really highlighted this. Most patients didn't speak English. Hospitals likely won't have enough in-house interpreters for a large international event. Social media might be used to request volunteer linguists, but they need rapid security screening. Ideally, you'd have contracts with medical linguist companies, maybe use video translation services, but it's a real logistical challenge requiring creative solutions.
Hadn't thought much about that one. And patient disposition dilemmas. After they're treated, where do they go? Especially if homes are destroyed or they're tourists, like in the Boston or Las Vegas events.
A huge issue. Hospitals can't become shelters. You need prearranged plans with transport services, taxis, buses, and predetermined community shelters, churches, schools to take stable patients, decompressing the hospitals.
Yeah.
Psychological support needs to be part of that discharge planning too. The trauma doesn't end at the hospital door.
Right. Okay, so pulling this all together, looking at the bigger picture, our sources stress that military and civilian trauma systems, though different, have unique strengths. And if you integrate them, you could move towards that ambitious goal. 0 preventable deaths after injury. A national trauma system.
That's the ultimate vision, leveraging the best of both worlds.
The military strength, forged in conflict, vast MASCAL experience, complex injury expertise, protocolized point of injury care, coordinated care over distance, clear command, focus on readiness. They're built for this.
Decades of hard-earned experience.
Yeah. While civilian strengths lie in high routine trauma volume, open access for all subspecialties readily available, routine data capture for quality improvement, integrated research, depth and breadth in daily care.
Constant high volume keeps skills sharp.
So the benefits of integration seem massive. Clear command, high volume experience shared mass scale lessons, readily available trauma networks, universal data capture, prospective research, uniform training from point of injury up, rapidly deployable assets. Truly the best of both worlds, right? A path to fewer preventable deaths.
It absolutely is. And this is where the deep dive really connects, recognizing how those military lessons can be applied and adapted civilianly. Principles like damage control surgery stabilized, now fixed, definitively later applied across the whole continuum, centralized leadership imposing order, and the idea of pushing capabilities forward, maybe not a full surgical tent at every urban MASCAL scene, but pushing critical interventions, hemorrhage control, airway management, maybe even blood forward to first responders, community hospitals, triage sites, that's directly applicable.
Bringing the life-saving care closer to the patient faster.
Exactly. Specific military-proven techniques, widespread tourniquet use, better pain control, advanced airway skills from TCCCC. Training these can and should be standard for civilian first responders. It takes commitment, leadership, funding, but the evidence is there. It saves lives. The overarching goal, military or civilian, field or hospital, is the same. Prioritize, stabilize, sort, and move the injured efficiently to definitive care. You strive for the optimal, even if sometimes reality forces you to accept the acceptable to save the most lives. But optimal is always the target guiding your planning.
What we've really unpacked today is just the incredible complexity, but also the profound life-saving potential in effective mass scale management. It really seems to hinge on three core things: leadership, deep expertise, and continuous realistic training. Optimizing those seems to be the difference between, well, chaos and coordinated care, between preventable deaths and lives saved. And the surgeon's role, as we've explored, is woven through every single aspect, far beyond just the operating room.
Absolutely. And this raises, I think, an important question for you, the listener. Triage in these extreme situations isn't just a science. It's truly a tactical art. It embodies leadership, clear communication under immense pressure, remarkable flexibility, crucial adaptability. It demands constant learning, rigorous system refinement through those vital after-action reviews. It's a dynamic, evolving process requiring continuous dedication from everyone involved.
So consider this as we wrap up. Given the ever-present risk of MASCAL events in our world today, what role can you play in fostering a more prepared, more integrated, more resilient community trauma system? Maybe it's advocating for universal training like Stop the Bleed, getting yourself or your community trained in those immediate life-saving hemorrhage control techniques. Or perhaps it's simply understanding the immense effort and intricate planning behind these critical responses, appreciating the dedication of those preparing for the worst, and supporting those efforts in your community. That goal of zero preventable deaths. It really feels like a shared responsibility, doesn't it? Requiring everyone's attention and commitment.